Hello, everyone. Welcome to today's webinar. Today's topic is how to plan for healthcare costs in retirement with Dana Anspach and guest Mike Smith and Stefan Cherneski. Dana's the founder and CEO of Sensible Money. She's recognized as one of the nation's leading authorities on retirement and decumulation planning. She's the author of Control Your Retirement Destiny, a popular how-to guide, which you can also find as a podcast on Apple, Spotify, and iTunes. Her acclaimed online course, How to Plan for the Perfect Retirement, is available at thegreatcourses.com and at wondrium.com. Sensible Money was recently ranked 35 out of 500 in USA Today's Best Financial Advisory Firms and named a Best Place to Work for Financial Advisors by Investment News earlier this year. And for the third year in a row, Sensible Money has been cited by Inc. 5000 as one of the country's fastest growing private companies. I'm Nancy Fellinger, a financial planner here at Sensible Money. I'm in Pawleys Island, South Carolina. While most of the team is based in Scottsdale, Arizona, we also have other team members in Massachusetts, Oregon, Indiana, and South Dakota. We work seamlessly with each other and with clients all across the country every day. With Dana today is Mike Smith, an independent insurance broker specializing in health insurance and Medicare planning. He's the owner and founder of Arizona-based MPS Insurance Advisors. Also with us is Stefan Cherneski, a certified financial planner and independent insurance planning specialist. He's a Connecticut-based member of the Professional Life Advisors Network. Mike and Stefan, would you like to share with us what it is that fuels your passion for insurance?
Absolutely. I've been very blessed to have been giving great guidance in my own family's health crises about proper insurance planning. My father was diagnosed with renal failure about a month before he started Medicare, and I got to see the process that he went through. And long story short, he had great insurance. He was given a kidney transplant, and it's made all the difference in our family financially and health-wise. Everybody's happy and healthy. So extremely passionate about doing the same for others and providing the same benefits so that everybody else can be protected in their own lives too.
Thanks, Mike. That's a great story. And thank you, Nancy, for that introduction, and Dana for having us here today in front of the group. So as Nancy mentioned, my name is Stefan Cherneski, and as you hear me speak throughout the presentation today, you'll definitely know that I'm Canadian. So you'll see that picture, a hockey picture on the screen as well, too. So I was born and raised 8 hours north of Winnipeg, Manitoba, for those of you who are geography fans. I was a first-round draft pick of the New York Rangers back in 1997, and then I came down to the United States to start my pro career in 1998. My 11th game as a pro, I ended up shattering my kneecap in 6 pieces, which unfortunately ended my hockey career after 4 unsuccessful surgeries. But the one thing that I did have in place was a disability insurance contract that my father insisted I purchase. So insurance is very important to me. It's played a huge role in my life. It allowed me to go to school, purchase a home, and start my life ahead of schedule. So I think I bring that same passion to the conversations I have with individuals and families today, working alongside the folks at Sensible Money. So I think we can really have good conversations about what insurance can do for when life doesn't go as planned. And once again, I look forward to the presentation today.
Thank you all. And so, Dana, let's get started.
Thank you, Nancy and Mike and Stefan and everybody attending. We had actually about 570 people registered for this webinar. So I know we are in what's called peak 65, more people turning 65 every single day than in the entire history of our country. And so this is a very important and relevant topic. Before we get into the meat, I have to go through our disclosures. So we will be talking through examples. We want to make sure that everyone knows that nothing we're talking about is a solicitation to buy or sell securities. And of course, we can tell you all kinds of stories and examples, but they're not yours. And so getting personal advice, customized advice in these areas is critically important. But you do want to know enough to recognize good advice from bad advice. And so we're hoping to arm you here with good, solid information that helps give you a sense of direction and know what kinds of things to look out for. We're going to be talking about 3 distinct phases of healthcare. the pre-65 phase. So what happens if you retire before you go on Medicare? How do you get health insurance? What might you expect to pay? What are some of the, tax credits or risks that you need to watch out for? So we'll be talking about that. Then we'll transition into talking about the post 65 phase, and specifically the transition on to Medicare, some problems that can occur if you don't do it right, and then the differences between traditional Medicare with a supplement and Medicare Advantage plans. And then we'll wrap up with the last phase of healthcare, long-term care. What happens later in life when we may need help with things around the house, cooking or cleaning, or we may not be able to care for ourselves, or perhaps, we have some more critical needs, cognitive decline may set in. So that's the general gist of what we're going to cover. We'll be kicking it off with this pre-65, which coincides with what you'll sometimes hear referred to as the go-go years. So we think of retirement in very similar phases. The go-go years where you're traveling, and oftentimes we're planning for you to spend a little bit more during that time. And then the slow-go years that often begin around your mid-70s. And then sometimes the later years are referred to as the no-go years. So kicking it off with the go-go years, Mike, talk to us a little bit about what are your healthcare options if you retire and you're not 65 yet and can't go on Medicare.
So there's a lot of different things that you can do. Everybody, for the most part, is used to having some sort of offer of employer coverage, so it can be a little bit of a daunting task when you want to leave work prior to Medicare, maybe 2, 3, or more years and out from when you're 65. But the first thing that becomes available if you've had insurance through a large group plan is COBRA. So that's always something that we want to look at first and foremost, because you're presented with that option. Sometimes it makes a lot of sense. Sometimes it doesn't make as much sense depending on your situation, but it is available. The other option that you have is you can use the Affordable Care Act, also known as Obamacare. The marketplace exchange plans. Some states have their own individual exchanges, but similar concept. There you can get some tax subsidies to offset your monthly premium obligations. Very helpful, as your income may have dropped a little bit as you retired, so we want to be mindful of that. There are some other options that are not on an exchange. There are different sort of privatized plans that you may have. Formerly we had the ability to write underwritten kind of short-term or tri-term plans. Those are not available except for 4 months in duration, so it all depends. I advise not trying to hobble those together to get through a year. It's not a good practice. So you have that, and then there are alternative plans like your Christian healthcare type sharing plans, things like that. So I just like to tell everybody there's always an option. You do not need to work for insurance if your goal is to retire prior to 65. So that's what you can do there.
And Mike, I'm curious about option one. I know, when I started in this business in 95, employer covered healthcare was more widely available. Do you see it that often now for pre-65 retirement?
I see a lot of people still have employer-sponsored health insurance. It does depend if you have 20 or less employees. That can have a bearing on what happens afterwards. So again, you do have that COBRA option to lean on for at least 18 months, in some situations as much as 36. It just depends. But yeah, that's something that you do want to pay attention to, and that can be something that's tied to a situation. Maybe the continuation coverage that you get from an employer helps a little bit with a chronic condition you may have. It ties you to a network of doctors that you may need to see. So that's something that we really want to pay attention to. And then obviously we want to be mindful of the cost there. If you just need insurance in place, I always kind of like to look at the Affordable Care Act for the subsidies. But yes, a lot of people still do have the insurance, but as more people work for smaller companies, it's not always as readily available.
Yeah, and I know you mentioned cost. We've seen cases where, COBRA was the less expensive of the two options, and cases where it wasn't. So it wasn't an automatic, if you have COBRA, take it. I think it's really a case-by-case situation that you have to look at based on where you're located. Would that be the case?
Yes, 100%. I mean, I say, any option that you have at your disposal, there's no bad ideas until you realize that something might be a little bit more efficient for your needs than option A, B, or C.
Yep, that makes sense. And speaking of costs, we found this on a Forbes article. It was current numbers looking at about age 50 that you might expect to pay about 750 a month or around 9,000 a year. But at age 60, you could expect to pay about 1,154 a month. That's almost 14,000 a year. That was for an unsubsidized Affordable Care Act plan off healthcare.gov. Would you say that's in line with what you're seeing?
Yes, as I help people all over the country with this, on average, that's very accurate. Again, those figures are unsubsidized, meaning you're not getting any tax credits to help offset that premium. So that can make something that looks like a pretty daunting number, that $1,000 figure there is never fun to contend with. But as your income goes down, we're always looking forward. It's possible to offset that premium with a pretty healthy tax subsidy if you've done some careful planning.
Yes, I love that concept, and that's what we're talking about next. So, the healthcare tax credit has changed quite a bit in the last few years. These were the old rules, which was what we'll call kind of a cliff qualification. So, these percentages you're seeing related to your income relative to the poverty line. So if your income exceeded 400% of the poverty level, then you were not eligible for any subsidies. It was like you could go $1 over that limit and boom, no subsidies. But a few years ago, that changed. And so this is the new rule that has been in place since 2021. And it works completely differently. So they benchmark your premium relative to the second lowest priced silver plan. So on the Affordable Care Act, Mike, I believe there's bronze, silver, there's kind of 4 plan levels. Is that correct?
Occasionally you'll see a platinum level plan, but they are rare. Most states don't have them, but if you do, I come across it every time. But yes, there's a couple of different levels of plans. Fundamentally, the difference between them is the out-of-pocket cost sharing. As you go up in metal level, changes a little bit from bronze all the way up to a platinum plan if it's available.
So if you were on platinum, you would expect to pay the least amount out of pocket, and if you were, for example, on the bronze plan, you would expect to have the most out-of-pocket costs. Would that be about right?
Correct.
Yep.
Yeah. And that's something that you really want to consider how much you use the plan to, because obviously with the out of pockets being a little bit different from plan option to plan option, if you're not a high utilization person, you may be able to save in some fixed premium, knowing full well that you can cover a potentially larger out of pocket if it did come up, but otherwise you're just paying more in premium for something that you may or may not use.
That makes sense. And specifically related to the tax credits, what these new rules mean is that at most, you will pay for your premiums 8.5% of your adjusted gross income. And so they basically benchmark your plan against the second lowest price silver plan, and they say, okay, at most, you will pay 8.5% of that benchmark premium. And so you will get a credit, related to the benchmark premium for amounts above that baseline. Now, if you bought a more expensive plan, of course, you're going to pay that difference. Your credit is going to be based on the price of this benchmark silver plan. Now, a couple things that happen when we talk about this being a percent of income. Income in this case is defined as adjusted gross income, and there's numerous versions of that, but specifically, it's adjusted gross income plus the non-taxable portion of your Social Security, plus any untaxed foreign income, plus any tax-exempt interest. So for example, if you owned a municipal bond portfolio in a taxable account, that would generate tax-exempt interest. You would have to add that interest back. If you had claimed Social Security early, you would have to add the non-taxable portion back in this formula. So it's never simple, but it basically works like this. based on how that modified adjusted gross income turned out, here's the annual subsidy that you could potentially qualify for. This was based on a 60-year-old couple, and the benchmark plan was out of Hillsborough County in Tampa, Florida. Now, we have had clients that qualified for substantial subsidies that had $2 million, in some cases $3 million portfolios. I know that sounds very bizarre to many people listening, but as Mike said, with proper planning, many people can qualify for these subsidies because modified adjusted gross income is not the same as cash flow. And oftentimes with advanced planning, there's ways to structure your portfolio so that bonds or CDs would mature. And when that matures, let's say a $100,000 CD matures, that's not taxable income. Only the interest on that CD was taxable and included in this formula. So there's ways to structure this. We have a client drawing $11,000 a month out. The second of the couple turns 65 next year, but they've been able to qualify for over $20,000 a year in subsidies for the last few years, and it's made a meaningful difference to them.
Absolutely. And one more thing I'd add to that is if you have more dependents that you're still, say you have children that are above 18 but below 26, if you claim them as a dependent on your tax return, that actually aids in inflating the subsidy a little bit. And even if one of the spouses comes off of the ACA to potentially go on Medicare or something like that, they are still counted towards the tax household. So the subsidy still remains in place and everything like that. So that could be really helpful as well.
Oh, that's great to know. Now, another thing that comes up in this pre-age 65 range are health savings accounts. Mike, you want to walk us through the basics?
Absolutely. So I believe in health savings accounts. They're very powerful retirement planning tools that I think get overlooked a lot of times. Basically, they're a triple tax advantaged account that you can open provided that you have an eligible high deductible health plan. So a lot of employers offer those. In addition to that, you can also get them through the marketplace, and there's a few other options to get that qualifying coverage. But it allows you to make pre-tax contributions to an account for eligible medical expenses that potentially can grow tax-free inside of the account. And then when you take it out for qualifying expenses, are tax-free in withdrawal. So it's very helpful. You can save receipts for many years of medical expenses if you don't want to draw on your health savings account and get reimbursed in 1 year, and it's a non-taxable event. So very, very helpful for some income planning down the road. You can use those HSA funds to pay for Medicare premiums in the future from the government, things like that. So it's definitely worth looking into for sure.
Yeah, I love HSAs. I fund mine every year, but I don't use it. I want to let it grow. It's another way to grow money tax-free. So when I see people that fund them every year and then turn around and use them, that's not a bad strategy, but it can be a great way to just supplement your retirement savings by funding it and then not actually using it. You just let it grow, and then we come up with a strategy to use it. It's not the most efficient account to pass on to the next generation, so we do generally like to see people spend these down, generally between about age 70 and 80. Now, I know a question that always comes up is that you can use HSAs to pay your Medicare, your Part B premiums, for example, but not to cover a Medigap policy. Correct, Mike?
That is correct, yeah. And all the disclosures for those types of policies, they'll say not to be paid with HSA premiums. That is a private insurance contract. It does not receive federal subsidies. Therefore, it's exempt from being able to use that to pay premiums. So yeah, if you're doing that, you want to avoid that.
Yep. And Stefan, another question that often comes up is that you can pay qualified long-term care premiums out of your HSA, but subject to IRS limits. How does that work?
Yeah, so what the IRS has charted out, and they're called age-based limits, depending on how old you are, and it's typically banded, is there's a portion of your long-term care premium that can be either used as a deduction if you itemize up to certain limits, or you can also choose to use your HSA to pay those premiums up to the age limits as well for qualified long-term care plans. And what a qualified plan refers to merely is as long as it's defined under the IRS tax code under 7702B, then it's considered a qualified plan. But there are the ability to use either your HSA or take certain deductions if you itemize for qualified long-term care plans that you may implement.
Yeah, and it's interesting because I haven't seen a lot of that, but then HSAs are still relatively new. So when I think about if people could start funding these early, right, by the time they got to the point where they were purchasing long-term care insurance, like this could be an absolutely wonderful way to cover that premium.
Yeah. And what I do see a lot of, Dana, is basically in conjunction working with somebody's tax professional in years where they can itemize deductions and they qualify under the 7.5% limit. They can just take those right off of their taxes there. And then in future years, they can save those funds inside their HSAs to pay those long-term care premiums. So there's a little bit of a way and a flexibility to choose which option is the best for you. But once again, right, this is all about having the conversation and seeing where we can take each individual.
Yep. Now, I know I have this listed under the pre-65, but just to clarify, you can still cover those long-term care premiums out of the HSA post-65, correct?
That is accurate.
Yep. Okay. And just, for our audience out there, the 2024 limits are $4,150 if you are 54 or younger, and $5,150 that you can put in if you're 55 or older. So you get an extra $1,000 catch up. And then there's family plans. And so the family plan limit, if you had a spouse, on a qualified plan, you can put up to $8,300 in. If you are both 55 or older, you could each put an extra $1,000 in also. So shifting into actually, there was a few other things I wanted to touch on, and it's related to some of the tax benefits. So, Stefan, I know we talked about the ability to pay long-term care premiums from the HSA. Another thing we've encountered, though, is the ability for a self-employed person to deduct these from their, as I believe under the self-employed insurance deduction.
That is correct. So there are certain tax advantages associated with businesses purchasing long-term care coverage for either the business owner themselves or their employees, which for pass-through entities usually might be the business owner themselves and their family. Typically, in general, right, if it's a C corporation, that's where you're going to have the largest tax advantages for those business owners out there. And then depending on the exact structure of the various flow-through entities, there could be additional tax benefits by utilizing the company to pay for those long-term care premium dollars as well. A lot of it is dependent on who the ultimate benefit is flowing towards, whether it's the employees who are not owners, as well as versus if it's the employees who are also owners. So kind of a little it depends situation there as well too. But once again, there may be some tax advantages by implementing a long-term care plan through a business for the owners themselves and or any of their key employees that they wish to cover as well too.
Yeah, and where I've seen this come up, we do tax reviews for our clients, and so we might have someone who's a real estate agent, or they're self-employed, they don't have employees, but they still fall under this self-employed provision, and they forget to tell their tax preparer that they are even paying long-term care insurance premiums. And so that deduction gets missed simply because it never crossed their mind that was information their tax person needed to know. So it's good to pass along, make sure you're sharing these things with who prepares your taxes. The other thing we've seen that flows a little bit more into our next section, the post-65 plus section, is once someone's paying their Medicare premiums, we have seen, again, they didn't relay that information to their tax preparer. They could have deducted those premiums under the self-employed health insurance deduction. Instead, they were taking them as itemized. We actually were able to help one person go back and amend 3 years worth of returns and get about a $7,000 refund because that deduction had been missed for a couple of years. So good to know, you need to communicate these things to your tax person. They wouldn't know to even look for the deduction unless you're letting them know that this stuff is going on. Moving into the post 65 phase and the transition onto Medicare. Now, I'll tell you one thing, Medicare is not simple. And so one of the myths that we've seen that luckily I don't see as often is that, oh, Medicare will cover all my costs. I don't have to worry about health insurance costs once I'm 65. But this is an overview of the 4 parts of Medicare. Mike, walk us through all of this that's going on here.
Sure. So this is undoubtedly a little bit confusing, but basically, as you look at the left side of these columns, your government insurance that you pay taxes for your entire working life is going to be Part A and Part B. And what that means is Part A is hospital coverage, meaning I think of this more as hotel hospital. It's not the surgeries in the hospital. It's not things like that. It's just basically room and board at the hospital is what you think of this as. And that has a period deductible of $1,632. That basically buys you 60 days in the hospital for room and board. So it's powerful. If you've worked 10 years or 40 quarters, that is no additional premium to you. So that's the good news there. So a lot of people will take that, even if they're still working at 65. It doesn't really hurt you unless you have an HSA account. We'll talk about that a little bit later. But then you have Part B, which is really what I consider the strong arm of your Medicare coverage. And that's going to be all of your medical insurance from the government. So that's partially funded by all your working years. This year, the base level premium is $174.70. So that's basically uncapped 80/20 co-insurance from the government, meaning that the federal government, Medicare itself, is going to cut a blank check for 80% of all your healthcare needs, as long as it's a qualifying Medicare procedure, tests, surgery, anything you can think of like that. Bad news about that is you're also agreeing to a 20% co-insurance that you would pay, and there is no cap on that with original Medicare. So that by itself, parts A and B, I call that the passport to Medicare. That's the basis of everything, right? So if you're going to use your original Medicare benefits, there is no prescription drug coverage in parts A and B. So you would get a Part D standalone prescription drug plan to cover the cost of your medications. There's various plans available through insurance companies that receive federal dollars, but those are strictly used for prescription drugs that you pick up at the pharmacy. If you're talking about an inpatient or outpatient type of medication that you're receiving, that would actually be covered under Part B. So just remember this, if you remember anything about it at all, Parts A and B are, what everybody starts with, and then you get to make decisions from there. So if you stay in original Medicare, you'll use A, B, and D in conjunction to receive your government benefits. Or you can move over to the other side, which you see listed as Part C, and that's what we call Medicare Advantage. So those are the plans that you see advertised heavily on TV right now. We're in the fall enrollment period. And what that really means is you've assigned these 3 benefits, Parts A, B, and D, to a private insurance company that now manages your Medicare benefits. So it becomes an all-in-one type of plan that includes all those benefits inside of it. So you will never have A, B, C, D. You just have A, B, D, or C. So it's pretty cut and dry. I call it the fork in the road decision. Do I want to retain my original Medicare, Parts A and B, or do I want to assign it to a insurance company and go with a Medicare Advantage or Part C plan?
Well, it doesn't sound so simple. Question, I know we're going to talk about enrollment in a minute, but you enroll for each of these things separately, correct? So we think about signing up for Medicare, but really you're signing up for Part A, but doesn't mean you're necessarily signing up for Part B, and then you're signing up for Part D. Those are all separate things, correct?
Correct, yes. So you have the option, let's say, good example is someone who's going to continue working past 65. Provided they don't wish to make an HSA contribution, you can enroll in Part A strictly by itself. There's no premium to that. You will have a Medicare number issued to you. You won't have the Part B attached to it, but you can opt for that alone and then trigger your Part B when you actually retire. Or you can do it all at once. Part of the application is saying, do you wish to enroll in Part B as well? Let's say you're just going to retire when you're 65 or you're already retired. You're going to want to go ahead and do that. That's going to be the core of your Medicare benefits. You're going to get your card in the mail, the red, white, and blue Medicare card. It'll have a Part A and B effective date on it. And that actually acts as your ability to then choose to enroll in a Part D plan of your choosing, or go ahead and enroll in a Medicare Advantage or Part C plan. So you have to have A and B to get a Part C plan. And you can get a Part D plan, even if you technically just have Part A, but there's some nuance there. So just think of that. Yeah, you can enroll in it all separately.
Craziness. I know we're going to talk more about the enrollment process in a few slides, and we'll also talk more about traditional Medicare versus the, Medicare Advantage plans. But Stefan, one of the things that we hear a lot is this concept that, once I'm enrolled in Medicare, I'm covered for long-term care. Tell us how that works.
Yeah, I mean, and that is generally a misconception that I hear in a lot of the conversations that I'm having out there, is that Medicare covers long-term care. And that's unfortunately, it's not the case 100%. You think of Medicare as an extension of the health insurance that you have during your working years, and health insurance just basically does not cover long-term care services, right? That's going to cover you for illnesses and injuries, but not for any care that may be required after that. Right, so any care that you would be required, in some instances, Medicare may cover up to the first 100 days. And in those instances, typically the first 20 days are covered if you're discharged directly from a hospital, directly to a facility. And then for the remaining days from day 21 to 100, there's a significant copay. And currently in 2024, that copay is $204 a day. So even with Medicare, you're still potentially paying up to $6,000 plus per month if you are discharged from a hospital to a nursing facility after 20 days. So, and then after 100 days, right, you're on your own at that point in time. So really, we're out there trying to educate people about these kind of the ins and outs of how Medicare works. I know Mike's having these conversations and everyone else as well to say, listen, this is something that needs to be addressed, because if you think that it's going to be covering it, not necessarily that it will. And at the levels that it does, you're going to be there for an extended period of time, right? It's going to be woefully inadequate for that coverage there.
Yeah, it's really good to know, because, occasionally we do still see people that think, it's okay if I need a long-term care facility or assisted living or a rehab facility, like that's covered. And no, that's not necessarily the case.
Yeah. And I think the second part of that too, right there, is that for the people that are going directly from a hospital to a nursing facility, right, your choice of care environment is not necessarily yours at that point in time. So you have to be mindful that if there's a situation where you may end up needing care, do you want that to be your choice or the state's choice?
Yes. There's one more part that I'd throw in there too, is that what Stefan is talking about is skilled nursing. So there's requirements to even get there to begin with Medicare. So you have to be in the hospital for 3 days, 72 hours. And then you're discharged to a skilled nursing facility. But even though, just like Stefan said, it's extremely accurate, you get 100 days, but you don't necessarily get 100 days, because what can happen is if something has happened to you where you enter the skilled nursing facility and you're not showing signs of improvement, they're going to discharge you. And at that point, you do need to look into true long-term care planning, or, the coverage that you have in place is going to be what you lean on. So just because there are 100 days involved does not mean that you truly get those 100 days. So you want to be careful of that. Stefan's 100% correct on that.
Thanks, Mike.
Yeah, and we'll be talking more about ways to plan for and cover those costs. Right now, looking specifically at Medicare enrollment, one of the common questions we get when people turn 65 is, do I have to roll? Do I have to roll? Do I have to enroll? And the answer, of course, is it depends. Mike, walk us through this.
Sure. So unfortunately, this is not a one-size-fits-all, type of guidance here, but there are things that I listen to when I sit down with people. And just like Dana said, there is a big misconception that once you turn 65, you have to enroll in something. And I get that a lot of times when I'm on calls with people who want to know, well, I have to sign up for something, right? And the answer is not necessarily. You may not have to enroll in any part of Medicare, it just depends. So the one exception to that is if you're covered by a large group health plan, which is defined as 20 or more employees, you can forego enrolling in Part A and Part B. You don't need Part D or Part C or anything. You can just continue to use the same group insurance that you have as long as you are actively employed in that position at the company. The other nuance to that is if you have a spouse that's covered by that plan that's tied to your active employment, you can also delay enrolling in Medicare Parts A, B, etc. So that's one of those things. So long story short, you may not have to enroll into anything. You don't need to inform Medicare that you are choosing not to enroll in anything. It's kind of on you to make sure that those qualifications are met, and then you can forgo that. A lot of times people may sign up for Part A even if they have that. One of the things that I do want to talk about, Dana and I were kind of talking about this yesterday, is let's say you are working at a company that has less than 20 full-time employees. That is what they consider non-creditable coverage, meaning that you cannot delay Parts B or Part A for that. So you want to go ahead and take both in that situation, because fundamentally, if you're on that group plan after 65, the group plan acts as a secondary insurance. So if you don't have Parts A and B to act as the primary, you are now the primary insurance. The group plan is secondary, so you can be saddled with some pretty uncomfortable bills if you're not looking out for that. I usually advise everybody 2 things that you can look at to kind of tell whether those criteria are being met. One is you will get a creditable coverage letter every year saying that your coverage qualifies you to specifically delay your enrollment in the prescription drug part. And then you can go ask your HR at your employer whether the coverage that you have qualifies you to delay Medicare. So that's how that works there.
I want to bring up a story you and I were talking about related to that. So it was a horror story that we heard, and I think the person telling the story was actually working with a Wall Street Journal investigative reporter. The story was supposed to come out last weekend. I didn't check to see if it did, but it was a case where someone did ask their employer, but it was a less than 20 employee employer, and they were like, "Oh no, you're on our insurance. You don't need to enroll in Medicare." And so they didn't, and they got diagnosed with cancer, a stage 4 cancer, ended up, 8 months later, not realizing that, they weren't covered in any way, shape, or form. They hadn't enrolled in Medicare, and their coverage through their employer was denying all the claims. So it was, like $1 million of bills at this point coming in. And so we've always told people too to talk to HR, but it made me realize, if you're working with a large company, that's probably okay. But if you're with a smaller company, a lot of times they don't have an HR specialist or benefits specialist, and it's possible they may not have the best information. And so we all have to take self-responsibility and really double check. That's what I kind of came away with. Would you agree with that?
No, absolutely. And if you really want to be thorough, you can actually call the insurance company that you're with through an employer, and they can provide you that information as well directly, just to confirm what the HR department is saying. So a lot of times I'll see, there's some companies that are very large that I'm shocked if it's not creditable coverage. But again, if you start looking at maybe there's 10 to even low 20s in the number of employees at a company, you definitely want to make sure you're not falling into that boat, because there's calculations for part-time employees. It's not always cut and dry. So what Dana said is accurate. Just really triple check, make sure you're getting all the information, because that can happen. I've seen that happen, unfortunately, for some folks too. So you don't want to find yourself in that boat.
Yeah, and there was a couple other things I heard. One was a case where somebody was, they and their spouse, as you mentioned, were on their employer coverage. But it was a smaller employer. The spouse turned 65, and so they didn't realize that coverage would no longer be primary. And again, it was one of those just cases where, they get medical bills, the claims start to get denied. They just didn't know. And, the working spouse was not yet 65. So it kind of just didn't come up to the top of their mind to say, oh, we're still on your employer coverage. But Those are some specific cases to watch out for, to help your family and friends watch out for that. If you have anyone turning 65, regardless of their coverage, they really want to take a fresh look at it and make sure they're enrolled in what they're supposed to be enrolled in.
Yep. And the other one that I see that's come up a few times is, let's say that you are offered an exit package from a company where they say, we'll keep you on the insurance for the next 2, 3, 4 years, something like that. And we're just going to pay for it at 100%. Sounds like an excellent deal. But again, if it's not active employment, that's still, even though the coverage is creditable, you are not meeting the definition of active employment to qualify you to delay Medicare. At that point, if you have a younger spouse that's not yet 65, you can ride that out. That's a great benefit. But if somebody is 65 or older and you get that news, you do want to transition to Medicare coverage to avoid any problems.
Yeah, now in that situation, you could sign up for Part A and B, and then the employer coverage could essentially serve as that supplemental plan?
It could, yep. And then you would just make sure that the drug coverage is credible inside of it. That's when you really want to do some analysis too, because generally the out-of-pockets on the employer plans are a little bit higher than potentially a Medicare supplement. So you really have to look at the efficiency of how the plan is now coming together and the coordination of benefits between Medicare itself and the group plan. So again, not a one-size-fits-all situation, but the devil is always in the details. We just have to kind of take a look and know what we know and help somebody through that.
Yeah, and so that would really mean if you're offered a retiree medical or COBRA or an exit package, it doesn't mean and you're about to turn 65 or over 65. It's not an automatic, yes, that's what I'll do. You really need to examine your options.
Yes, absolutely.
Yep.
And then I think you're going to talk about it too, but the COBRA coverage, you definitely, if you're over 65 and somehow you're still being offered that is not creditable coverage. You need to take Medicare for that to work.
Yeah, that was another horror story I heard at a conference last week was, someone who was like, I'm covered, I'm on COBRA, but they were, had turned 65 while on COBRA. And again, they didn't know that they needed to enroll in Medicare. And you would need to enroll in that case in Part A and B?
Yes, because Medicare is going to be primary. Another kind of cautionary tale about that piece there is, if you have the COBRA and let's say it's either heavily subsidized or you've been given some sort of benefit to pay for it, I do run across that as well. That COBRA coverage has an 18-month limit on it. So a lot of times if there is a health condition that somebody has, you could run into a situation where after you've basically triggered your Part B and you've been on Medicare for longer than 6 months, you now have to get health questions be asked of you to obtain a Medicare supplement. And that can get a little bit convoluted there in how somebody can transition into other coverage. So you definitely want to evaluate that. That's definitely a look before you leave situation.
Got it. And there's also penalties. So if you were supposed to enroll in Parts A, B, or D, but didn't, and then sign up late, you can be assessed. Is it a permanent lifetime penalty?
It is a permanent lifetime penalty. It's 10% per year of the premium. So that penalty actually grows over the years as the Medicare Part B premium grows. That premium, that's going to stick with you for life, unfortunately, if you're assessed that. Part A, most people qualify for that premium free. So again, that's always the concern. Well, I at least have to sign up for Part A. Well, as long as it's zero premium, even if you delay it, 0 times any number is still 0, so there's no penalty there. There is, sometimes you'll run across people that have to pay for Part A because they don't have enough working credits. The way that works is if you delay Part A when you should have had it, and this is for the people that have to pay for it, the penalty only lasts for as long as you should have had it. So if you went 2 years without it, it'll fall off after 2 years. Still very uncomfortable. Those premiums are large, so you just want to make sure that you cover all your bases. The Part D penalty, that, not to make this any more difficult than it already is, but it's 1% per month times the national average prescription drug cost. So right now that's in the $30 range. So every month, if you go 2 years, it's 24% of that number is what you would pay in a penalty. And that is a lifetime penalty for sure.
Wow. Wow. So you definitely need to be paying attention and sign up when you're supposed to sign up. Now, I know if you are with an employer over 20 employees, um, we talked about you can enroll in Part A, it's premium free, but some reasons you would not would be if you were funding a health savings account. So if you delayed the enrollment of Part A and B because you had creditable coverage, then you could continue to fund an HSA account. Other than that, if you didn't have an HSA, is there any reason why you just wouldn't enroll in Part A when you turn 65?
No, it doesn't hurt you to not do it, but there's no reason if you're not going to make those HSA contributions to not take it. It's just then it makes it a little bit easier to sign on later, and only slightly easier because now you have a Medicare number. You just have to activate your Part B coverage. So that's the thing. Only thing to look out there is if you work past 65 without taking Part A, when you actually apply for Medicare Part A and B, they will backdate your Part A coverage 6 months from the time of application. So there could be an overlap with an HSA contribution that could create a little bit of a tax liability that could be cleaned up, but it's unpleasant for sure. So you just want to be aware of when you're doing that, really have your dates lined up for when you need to stop making those contributions if you're doing that.
Yeah, and as a practical example on that, let's say you work till 68, and you were going to enroll in Medicare on your 68th birthday. So they would backdate your Medicare 6 months. You could still do half a year's contribution to that HSA, assuming it was your birthday fell so that it was exactly half a year. So you can prorate those HSA contributions the year that you enroll in Medicare.
Absolutely. You just want to be careful there's no overlap. And other than that, you're absolutely fine to do it.
Yep. Now, to complicate things even more are these Medicare enrollment months. And so here we have age 65, and you have this window of time. So generally it's 3 months before you turn 65 and 3 months after when you can enroll. If you enroll in the 3 months before, you follow these gray bars and coverage will start the month you turn 65. If you enroll at 65 or later, generally coverage will start on these bottom gray bars the month after. Now, there's this special rule if your birthday occurs on the first of the month, where you get an extra month where you can enroll, and now your coverage would start the month before age 65. This is craziness, right?
That is correct. I still am not entirely sure why that is the way it is, but it is accurate. So basically, if you're somebody who's lucky enough to be born on the first of a month, your coverage is going to start the previous month. So just think of it, that 3 month window shifts over 1 month for you. So so if you were a January 1st birthday, your Medicare actually would start the previous year for December, just to kind of frame that, how that works. But yeah, generally 3 months before, and what you're saying is true, that's always just based on the first. So it's the first of a month. So if you're 3 months away, your Medicare actually starts on the first of the month that you were born, unless you're born on the first, but let's say you're born on the second or later, always the first, and that 3 month period starts on the first of whatever month is 3 months preceding your birth month. And that always starts your birth month of 65. And then, it just every month after that, let's say you wait until the 15th of December because that's your birthday. January is the month it's going to start, and then it just rolls over month after month.
Now, you and I talked yesterday about some problems that we're seeing because I mentioned peak 65, more people turning 65, and thus more people enrolling in Medicare. I don't know how well the administration is staffed for this volume of people. And so you said you're not really seeing problems for the people that apply before 65, but for the people who may have had creditable coverage or they're applying after 65, there's been this delay in processing. So even though you may apply on time, they're not processing the application on time, which could leave you a gap in coverage. Have you seen some of this?
I have a little bit, and then at best case scenario, sometimes if it's heavily delayed, somebody just kind of knows they have Medicare, but they don't have a number, and they kind of push it back to, when the application was supposed to have been processed. But it's very challenging if you have any sort of medical issues that come up in that period, and it's not very comforting. So I always tell everybody, whether you're turning 65, retiring, start as early as you can, because it is the government, it's paperwork, things happen. Just give yourself as much of a fighting chance to be done in a timely fashion. We don't want to wait until, April 15th always to start doing our taxes. Same idea here. Earlier is better. And then, but yeah, for the most part, if you're turning 65, it's been pretty quick. In the fall season here, as Medicare is processing more information, it can be delayed a little bit. So yeah, again, just early is my advice.
Yeah, and we've heard, best practices, even if there's going to be an overlap with your current coverage, it would be better to make sure you're enrolled and have a month or two of overlap than take that risk that there's going to be a processing delay. And now you're going to have to fight the insurance company to get things backdated. Yep. And yeah,
it can
nobody
be very
can
difficult.
go through that. Yeah. Now, we talked about HSAs, and I think we really covered this, but if you have creditable coverage, then you would forego all parts of Medicare to continue to make your HSA contributions. Now, some things about automatic enrollment. If you're taking Social Security, you will be automatically signed up for Part A when you turn 65. You really have no choice. It's just boom, automatic. I don't know that you can even go in and turn it off. Do you know that?
Yes, you're actually, if you're drawing Social Security benefits, let's say you're a non-working spouse, that's where I see this happen a lot. You're a non-working spouse that's actually drawing Social Security benefits 4 months prior to your 65th birthday. You're actually enrolled in Medicare A and B automatically. You're just going to get your Medicare card, and it tends to come right before that third month of your window. So if that's the case and you're drawing, you actually can turn off your Part B. You have to have Part A to keep your Social Security going. But if you have other, an offer of employment coverage or something like that, you can absolutely turn off your Part B. So you don't need to take it. Quick way to do that is you sign the card, you flip it over, you send it back. They'll send you a card with just Part A on it. So don't miss out if that's your situation.
Interesting. I've also heard of a case where, like you described, the one spouse was not working but was receiving Social Security, automatically got his or her Medicare card at 65. And so when the other spouse turned 65, they were waiting and their card never showed up. So they thought it was automatic. And again, they missed their enrollment date just because, that's how it worked for their spouse. They just thought at 65, they send you this. Hey, I don't have to do anything, not realizing that they were not claiming Social Security yet. And so they had to actually go and you enroll through the Social Security Administration. And so they actually had to go to the SSA.gov site and then enroll in Medicare, set up an appointment, or I believe you can do it online. Is that true?
Yes, both ways. Online is pretty quick these days. That's generally what they would like you to do, less processing. But yeah, you do have to manually do it.
We talked a little bit about this Medigap versus Advantage. Tell us a little bit about the differences and some of the pros and cons of each.
Sure. So I just call this decision the fork in the road Medicare path that you're going to take. You're either going to go with basically retaining your original Medicare, which we can call the Medigap route, or you're going to go with an Advantage plan, which is the Part C route, right? So on the Medigap side, big pro of that is when you have your original Medicare benefits, you can use any doctor, any hospital, anywhere in the country that takes Medicare. That's the network. So in a sense, it's just Medicare is your network. Whoever takes it anywhere, you can go there. There is no prior authorization with that. You can just go in. If your doctor orders a procedure or a test or something, it'll flow through Medicare, no questions asked. So you have a high level of freedom of choice on that side. Very wonderful and very low out of pockets when you pair it with a Medigap plan. So essentially your annual bills this year could be at most $240 for approved Medicare procedures. So very helpful there. The big con of it is unfortunately to have the Medigap plan, or the Medicare supplement is also what it's called, and a standalone prescription drug plan. There may be additional premium that needs to be paid. So on a monthly basis, it may be slightly more expensive. That's the only con of that side. And then on the other side with the Advantage plan, the big pro of that is it's a lot of $0 type plans. So there may be a small premium or no premium depending on where you live and what plan you want to choose, but it can be a low cost monthly number. The big cons to that a little bit is you are dealing with managed care. So it's an HMO or a PPO type plan. So there's some network restrictions, things like that. There's co-pays, there's co-insurance, there's out-of-pocket costs that you would only pay as you use the plan. So in a bad year, you could face a higher utilization cost that affects your bottom line a little bit there. And then again, you're just dealing with network coverage. I tell everybody there is no right or wrong to that. It's an individual choice, whatever you find value in, but that really is how it is laid out there.
Yep. And I would agree there's no right or wrong. However, from a risk standpoint, from a financial risk standpoint, we typically tell people, look, if you can cover the premiums, we know we're going to be able to cap your costs. So in a worst case scenario, you're going to have much more financial protection over here with a Medigap plan. And that's what we really want to watch out for in retirement, are these big risks that could derail your plan. And so we view the Medigap from a risk management perspective as the safer choice. Would you agree with that?
I would say, yeah, it certainly lowers the costs. So it makes it very known, you know what your premiums are. It's a little bit more predictable, things like that. And just you might have a somewhat easier time using it again because of the non-network restrictions and things like that. So I tell everybody, if you like the idea of that freedom and you don't mind paying a little bit of an additional premium, not a bad way to start, just because it's a lot easier to move from a Medigap plan to an Advantage plan in the future than start with an Advantage plan and go to Medigap, because a lot of times you can always return to original Medicare, but those Medicare supplements or the Medigap plans require health questions be asked if you've been on a Medicare Advantage plan longer than a year. And that can be problematic if you wanted to make the switch and maybe you've had a couple of unfortunate episodes with some changes in health. You can actually be excluded from having the policy, or the policy could be rated to a higher rate. So, just food for thought there, but never a question with Advantage plans. There's no health questions for those. You can go over there anytime.
So just to make that clear, if you're here in an Advantage plan and you were to have some health issues, essentially underwriting could be required for you to move back over here. So you could be permanently here on an Advantage plan simply because you no longer qualify to get the Medigap. Is that correct?
Well, it would be the more efficient way. You're never required to stick with the Advantage plan, but your option would be, again, if you can't qualify for the supplement, you would just return to original Medicare, and that would create that risk of an uncapped exposure for you. So that could be catastrophic to your financial plan. So I always recommend, you want to either have an Advantage plan or a Medigap plan or something to contain the cost.
Yeah. Now, speaking of containing costs, this was some data we found on T. Rowe Price that was also current 2024 numbers, and they were just framing things in terms of low, medium, high, very high costs, really related to, costs could come from risk factors, things like hypertension, diabetes, asthma, depression, cancer, heart disease, things that might put people in this very high cost category. And so here they were talking about, someone that had Medicare only, A, B, and D, Medicare Advantage plan, or Medicare with the Medigap policy, also called Medicare supplement. So you'll hear the term Medigap, Medicare supplement. And so here they were just framing the actual cost, out-of-pocket costs you might experience. This didn't include costs for dental, vision, hearing. It was really, things like deductibles and co-pays. And so, here we see, in this case, the Advantage plan had a lower estimated out-of-pocket cost. However, I believe in certain scenarios, like you said, Mike, these plans could actually result in higher costs than one of these other choices. it just, not probably than just basic Medicare, but you could see an Advantage plan in cases that resulted in higher costs than the Medigap. Is that correct?
Yes, if you have a bad year on an Advantage plan, potentially just because of how the standardized Medigap plans work, you would have a higher out-of-pocket cost as you see doctors and do procedures and get treatment for sure. That is a thing. And then like you said, the Medigap plan, it does limit that to a very manageable level. You just have that additional premium. But, you can see Medicare by itself with nothing behind it has a higher cost even in this example. So I don't.
Yeah, and we're going to look at an even worse example. But just kind of sticking with this, so I think of it in terms of my primary goal was to manage and have the lowest monthly costs. The Advantage plan might accomplish that for me, but I am retaining some of the risk that I could have a year with really high costs versus if I was willing to pay a little bit more on a monthly basis, I'm now capping my worst case risk.
Yes, 100%. Yeah, you're giving yourself a little bit more exposure on that side for sure.
Yep. Now, I mentioned we'd talk about a worst case scenario. So this was a sample of, again, somebody with low versus high costs, but they had a Medicare supplement policy versus someone with no Medicare supplement policy who incurred a $100,000 event where they would have to pay $20,000 of that cost out of pocket. And so here we're seeing this first kind of orange bar is the estimates for premiums for Part B and D. And then the lighter peach colored bar is estimates on an annual basis of the cost of the Medigap or Medicare supplement policy. Then we had out-of-pocket estimates for dental, vision, and hearing. And then here was the out-of-pocket medical, deductible, and copays. And so as we were planning for this webinar, our conclusion was don't go naked. So don't go without some kind of a Medigap or Advantage plan that helps contain these potential costs if you were to have a heart attack or a stroke or an injury, an accident, a ski. I don't know if you're still skiing or, but you could be stepping off the curb and have some strange accident that ends up being an expensive event. So don't go without coverage.
Absolutely.
One of the last things we wanted to talk about in this section were just the IRMA premiums. So IRMA stands for the Income Related Monthly Adjustment Amount. And if your modified adjusted gross income, and of course there's a different definition of modified adjusted gross income here than in our previous definition, but if it exceeds these levels, then you will pay more for your Part B and D premium. So it's just something to be aware of. Sometimes there's ways to plan your income to keep you under the next threshold. Sometimes you can ask for a reconsideration. So these premiums are determined by looking at your tax return 2 years prior. And if you were to stop working and they're looking at your tax return 2 years prior when you were working, you can file and basically say, there's one of 7 reasons to request a redetermination. And so that can be something to consider. Roth conversions can put you over these limits. It doesn't mean you shouldn't do them, but it means these need to be factored into the analysis. So just something to be aware of as you're doing your planning that you could be subject to these IRMA premiums. And one other thing related to costs. So we talk about healthcare costs and the concern that they're going to be just exuberant in retirement. This is a chart of nominal costs. So these aren't inflation adjusted, but basically starting around 60 to 64 all the way through age 95. And this green bar is healthcare costs. And so we do see healthcare costs rising throughout retirement, but you have other costs up here that are declining. Transportation, because typically you're not traveling or as much, then you have travel costs. You can see that those get smaller. You have entertainment costs, apparel and services. Those tend to get smaller. So in terms of, total cost, we do see spending decline as people move through retirement. Healthcare takes up a larger portion of those costs, but it's often a substitution for entertainment and travel and other things. Now, when I say decline, when I look at this graph, it's in nominal dollars, which means if we were to put it in what are called real dollars that are actually adjusted for inflation, it would still be a rising line. It just means your costs are still going to go up, but not as fast as inflation. So that's what we typically see in retirement. And people in inflation adjusted terms tend to spend less in these slow go years. Still related to cost, when we plan this out for people as part of their financial plan, we create a timeline. So here was a sample of Sam and Sally on a healthcare.gov plan, unsubsidized, each paying $1,000 a month in premium. They were age 62 and 63, and we can see we expected those premiums to go up with inflation. Typically, we are using a 5% annual increase when we do this kind of modeling. And then what happens here is Sally turns 65, and so she transitions onto Medicare. And so we add in a Medicare supplement policy and her Medicare Part B premiums. Her out-of-pocket costs, we still estimate probably on the high side, but we're including costs for dental and vision and hearing. And so you can see her total cost actually went down when she went on Medicare. And then we see the same thing up here for Sam. So Sam turns 65, in this case, toward the end of 2027. So he's 66 in 2028 and turned 65 in 2028. And so we see as he transitions onto Medicare, his total costs went down. And that's very common. Mike, I think you and I were talking about this, and you see, universally as people transition onto Medicare, their total costs are usually less than they were the year before.
Yeah, absent any extreme subsidies in the marketplace or something like that, the premiums generally go down. The out-of-pocket certainly can be a lot lower, so that is accurate.
Yep, which is good to know. Now, where the costs can come from is as you enter those slow go or no go years. And these are the kind of costs that I think people really get concerned about when they're thinking about total healthcare costs in retirement. So, Stefan, you found this graph for us. Tell us a little bit about just, what you're seeing here in terms of costs and, really what's the difference between medical care and long-term care?
Yeah, Dana, and just in general, this chart is pulled from one of the insurance companies, and they talk about what the local cost of care is, and we can specify by someone's individual area, but just in overall across the U.S., you can see that based on the different levels of care that somebody may be receiving for care needs, you can see it goes kind of up the food chain from receiving care in your home, starting in $2024, from anywhere from around $6,000 per month, and then different facilities such as adult daycare at $2,000 a month, an assisted living facility at $5,500 a month, and then when you're getting up to a little bit more of a care in a side of a nursing home, you're looking anywhere from $8,000 to $10,000 a month, and these are all U.S. national averages. Depending on where you're located, right? This can change. I'm located up in the Northeast, where there is a higher cost of care for these services being provided. But once again, I think the whole overarching theme of this is, these are not small numbers that we're talking about here. So depending on what potentially can transpire later in life, you want to make sure that you have a plan in place for how to address these potential large numbers that may come your way. And the one thing you did ask about, right, and we did touch about on this earlier, medical care versus long-term care. Right? Medical care is going to cover injuries and illness and the treatment that's needed right after that. If there's any care or rehab that's needed as a result of those injuries or illness, typically that's not going to be covered by health insurance or very limited. So long-term care comes in as saying when you need help, when you need assistance, when you need help for you to go about your daily activities and live your life to, how do you pay for that? And that's where long-term care comes in.
Yeah, I've heard it called the 6 activities of daily living. I don't have the list in front of me, but it
Yeah.
was things like cooking and bathing and
Yep.
do you
Yep.
remember what else is on that
Yeah.
list?
Yeah. So I can kind of run down that list right now. So it's eating, dressing, bathing, continence, transferring, and eating. Right. Or so those are the 6 activities of daily living. So typically, if you cannot perform 2 out of 6 activities of daily living, if you have an insurance-based solution, then you would be eligible to receive benefits. The other triggering event is also a cognitive disorder. And it's not just merely that you're forgetful or things like that. It's, a cognitive disorder, and then you're under a plan of care from a doctor that you need supervision. So that would be something like you may wander out into the street. You may take too much medication. You could leave the stove on, right? Something where you're a danger, and then to yourself potentially or others, and that you need that care. My little joke on this is that on a daily basis, my wife likes to tell me I qualify for long-term care, but I say that's her opinion. I have plenty of friends out there that think differently, but it's a nice debate that we have in our household on certain days.
It's interesting you mentioned leave the stove on. My grandpa on my mom's side has since passed, but he, was in a care facility, a nursing home care facility for cognitive reasons for many years. But one of the first things that my mom and her siblings noticed, he had begun leaving the stove on. So they would go over there and, find the stove on and been on for 3 days in some cases. And so it's an interesting thing, but we saw it in our own family as just this, people putting themselves in danger and not even knowing it.
Yep. Yep.
Yep.
And that's kind of the second bullet point that we're talking about here. Like, what is the number one cause of care needs, right? And we can kind of split that as we did the presentation, 65 and above and 65 and below, right? The 65 and above, the trend has been towards, cognitive disorders like dementia or Alzheimer's disease. In the past, it wasn't as the number one cause over age 65, but in recent years, the claims for long-term care or long-term care needs have been driven over age 65 for cognitive disorders. Under age 65, what we've seen as the number one cause of care is the side effects of cancer treatments, right, that leave the patient too weak to care for themselves. So that would be the number one cause of needing care for those younger than age 65. That's kind of the general trend that we've seen over the last number of years.
Interesting. I didn't realize that. I would have thought it would have been an accident of some kind, but it's from the cancer. That makes sense. I've seen loved ones go through cancer treatment, and it's rough. It's very rough.
Yep.
One other question, what about the median? We often have clients who want to know, well, how long does someone stay? What is the median length of stay? What are you seeing around that?
Yeah, most of the numbers that are available out there are for when people go into a nursing home and how long they stay there, right? And that's kind of something we'll touch on as we go through this presentation. But in terms of from a nursing home, usually the rule of thumb is when somebody goes there and you're a male, unfortunately, the length of stay is usually around closer to 2 years. And then for females, it's closer to 3 years, right? That's the general rule of thumb. But what that doesn't take into consideration is for people that start to receive in their care in their homes, and maybe they're not receiving what we call skilled care, right? Someone who's licensed by the state or a facility that's licensed by the state. Or people are receiving care by unskilled caregivers, friends, family, neighbors, right? So what's the length of care they've received from their home until they've had to move or progress up the food chain of care needs into some sort of assisted living or nursing home? So it depends, but right, we all are aware that care can happen anywhere.
Yeah, it absolutely can. Now, talking about ways to pay for that care, I said this last year when we did this webinar, but I used to use the term self-insured, and I was corrected by a long-term care agent friend of mine who she said, Dana, I hate that term. It's not self-insured, it's self-funding. So walk us through here the different ways that you can plan to cover this potential cost.
Yeah, so I think a part of all of this is having the conversations, right? So saying if something happens and I need care, what are my options? So for those people who have not had the conversation yet, and for those people that maybe that have and made the decision to self-fund, right? Whether you know it or not, you may be self-funding already because you haven't had the conversation. But self-funding is essentially taking on the risk yourself. That you have your assets, you have the things you've accumulated over your life, so that if something were to happen, that's where you're going to go to pay for that care, right? That's self-funding. And I think with that, it may be suitable for some people, it may not be. But in terms of we're making the decision to self-fund or not, I think it's usually a risk question, right? Do you want to take on all the risk yourself, or do you want to pass on some of the risk to a third party? And we'll get to some of the insurance-based solutions for that as we go down here. But I think really that's the question for most people is, do you want to self-fund or not, right? You may be able to, but some people still make the decision not to. They'd like to pass on some of that risk to a third party. So when we're talking after self-funding, we talk about Medicaid. Usually for Medicaid, right? So just to make a differentiation, this is not Medicare. Medicare is health insurance, limited coverage for long-term care needs in a nursing home, co-pays, et cetera, as we talked about earlier. Medicaid is essentially when your care is paid for by the state. So what that means is that the assets that you've had are potentially depleted. If you're a single individual, you may be left with as little as $2,000 of countable assets. If you're married with a spouse, with a healthy spouse, it's called the community spouse. There are certain assets that are protected, a vehicle, a home, and certain income and asset levels. But for the most part, your assets have been spent down, and the state will come in and say they'll cover for your care. So kind of based on where our conversations are going today, talking about protection, this is not something that we want most people to go through, right? We're here to talk about strategies and solutions that can help keep you away from qualifying for Medicaid. But once again, for certain people, Medicaid may be the answer as well too. So, but once again, for that means your assets are at a level where you don't really have much anymore. And at that point in time, your care would be covered by the state. Now, for those who have evaluated self-funding and said, okay, well, I may want to self-fund or I do want to pass on some of the risk to the insurance company. That's where long-term care insurance comes into play, right? So I typically like to generalize long-term care insurance as someone's interested in purchasing a bucket of money from an insurance company that if they ever needed care, that's where they'll go first before they go to any of their assets they've accumulated. Within those buckets that you can buy from an insurance company, there's certain bells and whistles that can be added to it. You can have it for any number of years that you're looking for, up to certain maximums. You can put some inflation protection on these products. Some of them have different features such as life insurance or cash value, but essentially think of it as a bucket of funds that you can go to. Now, most people are familiar with traditional long-term care insurance. That's typically the most cost-effective way to buy long-term care coverage, but it does come with some certain deficiencies, right? The biggest one that has kind of arisen over the last number of years is that when you buy a traditional long-term care policy, your premiums are not guaranteed. What that means is that if Stefan buys a policy in Connecticut today with a bunch of other people in Connecticut, the insurance company can come back in the future and say, hey, based on that policy we sold in Connecticut, we're losing money on it. Meaning people are going on claim earlier, they're going on claim longer, our investments are doing poorly, and they can petition the insurance commissioner and say, hey, we want to increase the cost of this coverage for this policy we issued in 2024 in Connecticut. Now, the insurance commissioner has the ability to say yes, no, or somewhere in between. Now, if you think about it, the insurance commissioner is working for the state, right? If the insurance companies go out of business, right, who picks up the cost of care for people that don't have any assets? It's the state. So you could argue that the insurance commissioners are inclined to allow these rate increases at a certain level to keep these insurance companies in business that offer traditional long-term care so that they don't have to pick up the cost of care. But once again, just to be putting it out there, traditional long-term care insurance, right, the premiums are not guaranteed. If you don't use the benefit for long-term care, there's no other benefits associated with it, right? It's purely long-term care coverage. And I think the last
a question on that before we move on, because we've, in the last probably 5 to 10 years, have many clients that send us their premium option notices. Basically, the insurance company sends a note and says, your premiums going up, or you can, and they might give them choices,
Yep.
of ways to reduce the benefits to maintain their premium at the same level. But I've also heard that when initially these policies were issued, the insurance company didn't have a lot of data to go on to understand what their claims experience might be like. And so there's some people that say we've probably been through the bulk of those premium increases, and the insurance companies may be pricing it more appropriately, also more expensively for the policies issued today, but those being issued today may see less premium increases in the future. What are your thoughts on that?
Yeah, so I can give, there's obviously unfortunately a large body of evidence of the premium rate increases for people who've had the traditional long-term care insurance policies. So even with the rate increases, if you were to compare the current cost for an individual or couple that have already had a policy, been subject to the rate increases, versus them going to the market and buying a brand new one today, they're still in a more cost-effective solution for the one that they purchased in the past, even with the premium rate increases. So they're still in what I like to call a good deal. Not saying that they're happy with the premium rate increases, but typically we're able to show them that, listen, you're still in a better priced product than if you got rid of it and bought a brand new one today. So yes, I think to say that the pricing for a traditional long-term care policy is probably a little bit more accurate than in the past. I think that would be a safe thing to say. But a lot of times there's more options available today, right? And that's kind of the hybrid options there that provide a little bit more value than what a traditional policy offers. And I'm excited about the long-term care market, because for people that are interested in exploring their options, there are a lot more options today than there were in the past.
Yeah, talk a little bit about what we call the hybrid policies.
Yeah, absolutely. So we talked a little bit about the traditional, and now the hybrids came in to assuage some of the concerns that people had with the traditional long-term care market. Now we're combining long-term care and life insurance and potentially some annuity features here. But what this does is it allows us to guarantee the premiums in most instances. So regardless of what the future holds, the insurance company can't come back and ask for more premium dollars from the individual. The second thing is, because it has other insurance benefits associated with it, that if you don't use the policy for long-term care, there's still a benefit. There's still value that gets provided to your family. So it's not a use it or lose it scenario. And the last thing that I like to add on these hybrids, the way they pay out their benefits, it's a lot different today than in the past. A traditional policy was a reimbursement style benefit. What that means is that you would incur the expense, show proof of payment, and then go to the insurance company and say, hey, these are long-term care expenses, and they would screen them. And usually the measuring stick is that the care is provided by a licensed health practitioner or facility, right? And they're licensed by the state to provide long-term care services. So if your services were not provided by a licensed facility or individual, the insurance company typically would not reimburse you for those. Fast forward to some of the products available today, they're what's called a cash indemnity model, right? So essentially what that means, that is, once you qualify, right? You could ask my wife, I qualify now. The insurance company agrees through their diligence process. The insurance companies will then send you a check each month for the amount you're eligible to receive, right? This is a cash indemnity model. So they don't care how those funds are spent, right? They just care that you qualify at the beginning. So once you qualify and they're sending you these funds, you can use these funds for in-home care, adult daycare, assisted living, full-blown nursing care. But what I like about this is that if you're going to stay in your home, right, what we call home-based care, which most people would like to, everyone really these days wants to stay in their home for as long as possible. If you're receiving that care by unskilled caregivers, friends, family, neighbors, these policies allow you to stay in your home and maintain your independence and receive care in the environment that you choose. Because once again, the insurance company just verifies you qualify at the start, sends you your money, and then you can spend those funds as you see fit.
Yeah, I like that too, because a lot of times at the point someone needs care, it's overwhelming trying to argue and fight with the insurance company, or they have family members trying to do it for them, trying to lobby on their behalf, what we call having an advocate. And
Yep.
it's just frustrating, and it makes you just I've seen people just at their ends wit trying to deal with this. So the nice thing about having just that cash pay is you don't have to deal with any of that at a point in time where you're already stressed.
Yeah, absolutely. And there's studies out there too that show that the people who are the advocates for the person who needs care or the person that's helping them, right? There's that level of stress that's added to them that unfortunately makes them more likely to need care themselves in the future. So by having a solution that's easy to use, easy to access, and from companies that are very reputable, right? It makes the whole process a lot easier and for everyone involved.
Yeah. Now, along those lines, because we were talking about making it easier on everyone involved, when we talk about this self-funding option, we run an analysis where we show people, an extended cost of a 5-year stay and whether they could afford it in their financial plan. But we also talk about the fact that even if you have the assets where you could pay for this, there's been a lot of research that shows if you have qualified coverage, you are more likely to get care and to get quality care. So there's that natural sense of like, oh, I want to protect my nest egg, and so I'm going to put off my care needs as long as possible. Whereas if you have coverage, you're much more likely to get the care that you actually need. Have you seen that also?
Yeah, because I think a lot of these, let's call it, we're more concerned about that nursing home care, right? So in-home care is something that's probably a little bit more manageable because of the lower expense associated with nursing homes. So for people that do have to go to the nursing homes, if they have a pool of money or the assets and the ability to pay for that higher level of care, they're going into the places that could be construed to be a little bit more higher quality, as opposed for those people that have lesser means or no insurance to pay for their care. Their options may be limited to going into facilities that the level of care may not be at a level that they've desired for either themselves or for those advocates for their loved ones. So,
Yep.
By having something in place, it does provide you the ability to receive a care or a higher quality of care in general.
Yep, it does. The last couple things to touch on, we have clients, of course, that want to buy into a continuing care community. That's basically this concept that you're going to move into a place and it's going to provide the different levels of care as you may need them. Talk a little bit about some of the risks, pros, cons that people need to watch out for when considering that.
Yeah, I mean, the overall concept of continuing care communities, it's fairly sound. I think that plays on people's desires to want to be able to age in place, meaning that if something were to happen, that they're not having to go to another location, they're not have to move to a nursing home, because these continuing care communities have the ability for people to have independent living. They have the activities for the people to engage in with other individuals and families and couples who live there. And also, as you move up the food chain, as I keep kind of mentioning, it has the assisted living and it has the full-blown nursing care available there. So once again, it does provide convenience for individuals who say, if we're going to move here, typically 55 plus, where they can stay in this one area and receive any of the care they need. Absolutely, it can be a very big convenience feature. But I think the downside to some of these places is obviously the cost associated with it, right? You may be staying at a place and paying for things that you may or may not ever need. And for that convenience, there's a cost associated with that as well, too. So I think it all comes down to having that discussion to see what makes the most sense. But they can be a very good solution for some individuals who are willing to kind of endure, or I guess may have that extra cost, and for some individuals who prefer to maintain a little bit more independence, right, then maybe not so much. But once again, it's another option that's out there.
Yeah, and we've had people even have their attorneys review the continuing care community agreements. There's some communities that require a large lump sum up front. So what happens if that care community goes bankrupt is a consideration. There's others where, people just didn't realize that, yes, the levels of care were available, but for an additional cost. So they would get billed for the additional care as they needed and hadn't factored that in. So those are some things that we have people watch out for. And then we talk about pooling resources. I mean, you mentioned several times, care from family and non-skilled care, your community member, which I always call it the Golden Girls plan. That was kind of in my mind, like, oh, okay, that'd be great one day. Me and my girlfriends from long ago are going to get this apartment together. And so, of course, there could be some fun options like that. But, realistically, if you have someone who's like, well, my family will take care of me, what are your thoughts on that?
Yeah, I think it goes back to kind of what I said about who ends up being a primary caregiver to anybody who may need care, right? So the impact to that person's health of providing care to someone in need can be detrimental in the future. So I don't typically recommend that the community-based care or the family care is the primary option. And that's why some of these insured-based solutions make a lot of sense, or once again, self-funding, where at least you have a plan for when you need care so that you can take that burden off family members. Now, can the pooled resources work? Absolutely. In actuality, typically you don't see that put into effect as much. But there's the old saying, right? Too many cooks in the kitchen is a bad thing. So it kind of remains to be seen. But I tend to encourage people to explore other options than pooling resources with family or friends.
Yep. And we're almost wrapped up for everyone. I know we're running long, but it's just a lot of great and important information. So the last thing on long-term care, and then we'll open it up here for Q&A shortly, is, we've heard about these states implementing a long-term care tax.
Yep.
What is this?
Yeah, so the one state out there that did implement a tax a number of years ago was Washington. So for individuals that did not have a qualified long-term care solution in place, whether that was a big policy that provided lots of benefits or a small policy that provided minimal benefits, that made those individuals exempt from that employer tax. But for those that did not have some sort of qualified solution in place, they were subject to a 0.58% tax on their income that would be used to fund the long-term care coffers for the state of Washington. Now, it's interesting that there's some legislation out there that's being passed through in Washington to repeal this act or allow people to opt out. So as soon as it's been implemented for a few years, there's already some legislation out there where they're talking about being able to put something in place for people being able to opt out from this. And then the general consensus is that that's the case and people start opting out, it's going to bankrupt the program. So once again, it's out there, and there's a couple of other states that are on the list where they're a little bit further along from the discussions with this. I would offer that in the election year, there's nothing that's pending that to be implemented. But of those states after Washington, California, Minnesota, and New York, they're all kind of further along in those discussions. But I don't think by any means we're at any point where they're anytime soon when any long-term care or qualified long-term care requirement would be put in place. But those discussions are out there and they're happening. But as of today, I don't think there's anything impending, so to speak, from a legislative standpoint.
So as of now, no Social Security-like program that we can just rely on and move on our merry ways.
No,
it falls on us. Yeah.
No, I know there was a couple of, so part of the election cycle, right? Our presidential candidates tend to make some statements out there, whether they hold true or not. But I know there was a recent statement by Kamala Harris where she was talking about using Medicare to pay for in-home care. And that was a statement that she did put out there. How that would work in actuality, I think remains to be seen. But that was kind of some bluster out there as well too. So it's talked about, but we'll see.
Always a lot of bluster during the election years.
Imagine that.
Well, wrapping up, we encourage everyone to have a plan, create a timeline of your expenses, what it's going to look like as you transition off of your employer coverage. Work with an agent that understands your healthcare.gov and Medicare options. Talk to your benefits department, or as we discussed, call your insurance company directly to find out if they're offering creditable coverage. Each year, evaluate your options during open enrollment. consider a plan and evaluate your options for covering long-term care needs in the future. There is Medicare open enrollment happening now, as well as healthcare.gov open enrollment. Mike, one thing we didn't touch on, and here we're going to open it up to Q&A, but there's a big change to Medicare this year. I believe they've described it as a $2,000 kind of cap on your out-of-pocket drug costs, but there's some caveats to that. Some drugs may not be covered. Plans that covered drugs last year may not cover the same drugs this year. So I've heard if there was ever a year where you needed to evaluate options, and once you're on Medicare, we didn't touch on this, but you should really evaluate your plan every year. Anything you want to add on to that?
No, that's really the gist of it there is it's great. It's a long overdue cap of $2,000 that's never been capped since the program started in 2006 with Medicare drug coverage. Very helpful to have, but as that kind of got shuffled around in a lot of the insurance designs, some drugs left formularies, and you just want to make sure that it's covered, because if it's not on a formulary, meaning your plan doesn't cover it, it is not subject to that $2,000 cap, and you could incur some higher expenses that may be able to be avoided. So yeah, definitely make sure you get everything reviewed this year.
Yeah, and as we open it up for Q&A, Nancy's going to come back on, and we're going to encourage people to type questions into the question box. We will stay on for probably up to another 30 minutes, but I want to touch on one other thing, because as you just said, Mike, and we talked about bluster, there's two things that came to my mind. One was that $2,000 cap. Well, it isn't really a cap, because if you have a drug that's not covered, and then you could still be paying more than that to stay on that drug. Is that correct?
Yep, you'd be paying full retail cost. It wouldn't go towards those out-of-pockets at all. That's exactly what we want to avoid.
Yep. The other thing I've heard that I forgot to mention earlier was with the Advantage plans, that sometimes they're marketed as zero premium, and that to just remember, zero premium doesn't mean zero cost. So there can still be co-pays and things like that. So it's just something to be aware of. It's like people might think that means free, and that's not the case. Anything you would add to that, Mike?
No, that's absolutely true too. If I could offer you a zero premium plan that covered everything at zero cost to you, there'd be no reason to have anything else, but that's just the reality, unfortunately. So yeah, just look at those out-of-pocket expenses as you evaluate your own health situation as it relates to the premium dollars you spend every month, for sure.
Absolutely. Well, we're going to open it up to Q&A. We have our next webinar. You'll find that on the bottom of our homepage of our website too, where you can find an enrollment link. But it will be in January, where we'll be talking about 5 steps to turn your nest egg into a retirement paycheck. If you're interested in a complimentary consultation with one of our planners, you can find on our website a link to our pre-meeting questions. And you submit those, they come right to me. And then we will mail you out a packet that includes a copy of my book and of the great courses. And then we will set that introductory meeting. There's no cost or obligation, but that's where we really tell you more about the type of planning that we do for people who are right at that point where they're getting ready to live off their acorns. So with that, let's open it up to Q&A. And Nancy, I'm sure there's questions that have been rolling in as we've been talking. What do you got for us?
So there have been questions that have been rolling in, and actually ongoing. I've been trying to respond to some of them. So my apologies if I ask a question that you covered, because I probably missed you covering it. That you may get something that sounds familiar, like, gee, I already answered that. So one of that, it's not really a question, Dana, but you know how we have used on occasion the Genworth long-term care cost of care map site. I don't know if that's something that maybe can go out to folks when we send them the replay, but that's the interactive map where you put in your zip code and you can get information about home care, community, or home care, like nursing care, assisted living, and so forth. So that was a great suggestion.
Yeah, Stefan, if you get us the link, then we'll send out the email. We can include a link directly to that in our follow-up email.
Absolutely.
Yeah.
Absolutely.
Perfect.
All right. Thoughts on finding ship help before signing up for Medicare? Any other resources to help with the search for Medicare and healthcare insurance? So we might
Mike, do you
explain
want
what
to take
SHIP
that
is.
one? Now, you can call Mike, who I believe is licensed in many states, as an option to help. But Mike, other options and resources that people have?
Yeah, I would tell anybody you have the option to do your own research on Medicare.gov. You have the ability to work with somebody from the state health insurance program as well, like they're mentioning. One of the things too that we kind of fit into that equation as independent agents, we evaluate all the same data with you. There's never a cost to use my services, or any, broker shouldn't be, charging you any fees to look at this. So it's just, if you like somebody that you can work with, it's just somebody who has the information. So all those options are available. Whatever makes you the most comfortable is what you should go with.
And I will add to that, we have referred many clients to Mike over the last few years and have gotten absolutely phenomenal feedback. The level of service that he offers, not just initially, but as on an ongoing basis when questions come up throughout the year or when your annual enrollment comes up. We've just gotten outstanding feedback. So feel free to reach out to him. His contact information is on the screen.
Happy to help.
Is long-term care insurance redundant with continuing care community, or do you need both?
Oh,
Stefan?
yeah. So I guess the answer to that is it depends, right? So what does that contract involve with that continuing care retirement community, and what involves there from the level of services? So from the initiation fee and the ongoing service fees, depending on the level of care, that can increase. But there's nothing that can prevent you from having long-term care insurance that can be quote unquote triggered or turned on as your need for benefits increase, specifically when you can perform the 2 of 6 activities of daily living or have any cognitive disorder that requires that higher level of service. So once you're in the facility or the CCRC, the long-term care insurance can serve as a buffer to pay for those future increased costs as your kind of fee schedule increases with the increased level of care.
Please discuss reasonable long-term care adjustments to lower premiums. So I'm assuming this might be reduction of benefits or time frame in order to lower premiums.
So I would this question be in regards to someone who has an existing policy?
It sounds like it's, yeah, Steph, I think that's what that is.
Yeah, so the biggest factor that I've seen in these increases out there, and the most meaningful way to keep your premiums in line with what you're currently paying, is to forego any inflation options that you have on that contract or reduce them significantly. From a general pricing standpoint, if you look at a policy today and you add inflation, I mean, sometimes that may as much double the outlay for that specific product. And that holds true for people who have been hit with these premium increases as well, where if you want to maintain that 3% compound inflation, 5% compound inflation, where the insurance company is going to charge you a lot for that, so to speak. So what I've recommended for people, if their daily benefits and their monthly benefits are at a certain level where they're comfortable with them kind of more or less staying in that range for the foreseeable future, is to dial down that inflation option with the intent to keep your total pool you've accumulated, your daily benefit, your monthly benefits where they currently are, and just kind of know with the fact that you're not going to have that higher compound inflation to go. So that would be the first place I would look from the inflation standpoint.
Mm-hmm. Yeah, and I want to add something to that. We will often see people who had that inflation factor on their policy, but now here they are, they've owned the policy for 12 or 15 years, and their benefits are at a sufficient level. So they're at a point where we could remove that inflation option and they still have a great baseline of coverage in place. And keep in mind that if you have a long-term care event, you're still having your other sources of income, your Social Security, your required minimum distributions from your retirement account. So you still have those outside sources of income that are continuing. So it's not necessarily that your policy has to cover, every dollar that you have, because you will still have other cash flow coming in.
Yeah, absolutely.
Is it true that some doctors and hospitals are increasingly not accepting Advantage plans?
That is somewhat true. I would tell you there's some hospital networks that have historically not accepted Medicare Advantage plans and continue to not do so. And then, just like any other network-based coverage, there are continuing negotiations between hospitals, doctors, and the health plan itself. So if a doctor opts to exit, their contract with a Medicare Advantage plan or other health insurance plan, period, yes, that may not be supported from year to year.
If my husband is on my company medical policy, but he is 68 and so therefore on Medicare A, can he still contribute the additional $1,000 to an HSA?
No. So if you're enrolled in any part of Medicare, then you cannot contribute to the HSAs.
Okay. What do you think of the health share ministries like Samaritan Ministries, MediShare, Liberty Health Share for a pre-65 retiree in good health? Do you have any clients that do this? ACA doesn't seem like an affordable option for me since I'm doing Roth conversions that would eliminate most or all of the subsidies.
I mean, I always say it's always an option that's out there. I actually don't deal in that at all, but the contract needs to be looked at because a lot of times what it will do is it'll exclude pre-existing conditions. And then there's usually a clause in there where it says we may or may not pay for services. And if we don't have available funds to cover your claims, you basically can't sue us. So it's just something you want to be aware of, look through the fine print of everything like that. But it doesn't have the guarantees of insurance. There's no money really backing it up other than the pool of resources that its members have contributed to the fund itself. So just kind of something to be a little bit wary of. Not saying it's a totally bad idea, but you just have to know how it works.
Yeah, and I'll add to that, when we do our plans for pre-65, we evaluate Roth conversions versus qualifying for the ACA credits. Most of the time, the ACA credits win, so we will forego the Roth conversions. But then once you turn 65, if you're delaying Social Security, we still get a nice 5, now 7, sometimes up to 10-year window where we can do Roth conversions before your required minimum distributions start. And so there may be some planning there that could allow you to do both.
I often quote you with clients where I say, Dana likes to say you can do anything, you just can't do everything, maybe at the same time. Dana, this might be more for you. Unsettling doom and gloom rhetoric is nothing new as it pertains to world events. However, it seems to be more dire and threatening than in the past. Are you currently moving your clients toward more defensive sectors, or do you consider all the news as white noise and thus advise clients to stay the course?
So we really consider all the news white noise. When you look at what's happened in the past, specifically if you're talking about, geopolitical and the election cycle, regardless of what party wins, the stock market has been, we have a lot of data in terms of just not even the stock market, the markets as a whole, how things have turned out over different economic sectors, World War I, World War II, all kinds of things that we can look back in history. So when I say, we don't for example, rotate equities into a more defensive sector, but we do have a defensive structure that's in place by default. And so we use a set of laddered bonds and a particular equity structure called Minimax. So Minimax means what mix of assets has held up best under a worst case scenario. So when we're looking at historical market returns, while you're in your accumulation mode, you traditionally build a portfolio where you want to maximize return for a given level of risk. That makes complete sense. But as you're changing to the withdrawal mode, your objective has changed to produce reliable cash flow, and it's the big downturns that can have the most impact. So our default structure is already defensive, because that's what's most important in retirement. So my answer would be no, we're not making specific changes because our default structure is already in place.
Somebody wants to know how to sign up for the 1/30/2025 webinar.
Well, I would guess by the end of today that if you go to our homepage, www.sensiblemoney.com, and scroll to the bottom, there will be a block in the bottom left of that homepage where you can sign up. They may not have it up yet, but usually it goes live, the day we do this webinar, then the next one gets posted.
And I think there'll also be a link in the follow-up email that's going to contain the link to the replay of this. So there'll be opportunities to do that. Yeah. Glad somebody's looking forward to the next one.
Maybe what we should do is include a link to the next one too.
Yeah. I've been trying to manage income to approach but not cross the Maggie threshold. How do I find reliable values for Maggie brackets 2 years in the future?
Well, your guess is as good as mine. So what we do is we take the current brackets, and they're all of the components, not all of the components of the tax code. Most of the components of the tax code are subject to an inflation adjustment. Unfortunately, the taxation of Social Security, those thresholds are not. But a few years ago, they did change the IRMA threshold, so they are subject to inflation adjustment. So every year when they adjust our tax brackets up, those limits will be adjusted. We use 2% when we're inflating the tax rates in our planning model. So you could take the current thresholds, increase them by 2%, for the first year, it's compounded, and then 2% for the second year to come up with an estimate. To give ourselves a margin, we use the current rates. So when we're really looking at, how much wiggle room do we have, we like to use the limits as they are today. And we know 2 years from now, like they're going to be looking back to today's limits or to today's tax return, but the limits will have a little bit more wiggle room. That way, if there's a capital gain that occurs, there could be an inheritance. We've seen clients inherit assets that cause taxable events. There could be all kinds of things that happen. So having that little bit of wiggle room, we find can make a difference.
Question for Mike is what this actually says. Question for Mike. So what is your thought about if the ACA premium tax credit subsidies expire in 2026? And there's a link to kff.org, and I can forward this to you later, Mike. And it quote, because the Inflation Reduction Act extends the enhanced subsidies for 3 years and not permanently, future marketplace enrollees may see steep premium increases when, let me see if I can truncate this, when the subsidies eventually expire. So do you have any information, thoughts there?
Well, it's been very generous for the last few years because of the Inflation Reduction Act. Just like anything else, we're going to have to see what happens when those actually expire, and then we'll just have to roll with the punches then. But essentially, it may go back to how it was before, where that was the drop off after 400% of the federal poverty limit might be what is the norm again, but we'll just cross that bridge when it comes to it. I do think it's been helpful in the last couple of years that a lot of people actually have started to use the federal exchanges for their coverage. So the numbers are growing, and that may help kind of lessen some of the premiums, even if they're not subsidized, if that makes sense. So we'll just have to see what happens. But I also do have a little bit of a inquisitive mind about what will happen when those go away, or if they will.
Okay. What would you consider a typical net worth for someone self-funding, and how much should they set aside?
Oh, so we used to use a rough number of 2 million, but that might be too low today. And the reason it's so hard to determine net worth is there's just different things we look at. So, for example, does someone have their home paid off? Home equity is generally not a liquid asset, but it can be considered a reserve asset that if you needed skilled nursing home, you would sell the home and use those funds to cover the cost. So a lot of it depends on the composition of your assets, right? You could have a significant net worth, but it could all be in private equity investments and real estate investments that have very little liquidity, and you're going to be struggling to cover costs out of pocket. Or you could have a very large liquid net worth, or even a smaller liquid net worth, and you could have pensions and Social Security and other sources of cash flow coming in. So it's hard to narrow that down to a net worth target.
Okay, I'm not sure if this is related to healthcare pre-65. I think it might be post-65 Medigap and Medicare plans, but the in quotes, depending on where you live, has been mentioned a few times. If someone has the flexibility to move, where could you find a list that shows pros and cons of various places to live?
Ooh.
In terms of premiums?
I think that's, yeah. In terms of premiums, there's availability.
Mike,
Whatever
you may
you guys-
have an answer. I generally see that for, more populated areas have lower costs and better options, whereas the rural areas, often have less options. I don't know, would you see that also to be the case, Mike?
I would say that, on the advantage side, sometimes where there are more rural areas, there tend to be less options for advantage plans. And then in terms of the premiums for both, something through the marketplace or a Medigap policy, it just depends. And it depends a lot on the regulation. So if you have a state like Washington has what's called a birthday rule, California has a birthday rule, New York is a guaranteed issue state at all times. So their pricing for Medigap plans tend to be a little bit higher than they do here in Arizona or in other states. So again, you want to kind of know, if you're looking at it down the road, kind of factor that into your plan. If you plan on retiring in New York versus Arizona, you can expect that your premiums may be a little bit higher in New York, at least currently. So you want to get a start on it and know that you have the available funds.
And Nancy,
yes.
So one of our planners is on, but he's on the chat feature. He just mentioned there's a website called healthshareguide.org. Oscar, can you type into the question, like you mentioned, it's a great website to help you evaluate. I think you were referring to the Medicare plans. So we'll see if he responds. I just sent it out on the chat. Mike, unless you're familiar with that website, it's healthshareguide.org.
I'm not, but yeah,
Okay.
there's available resources that you can definitely tell. I mean, you can also look at all the different quote tools and stuff that various brokers have. I have one myself that gives you a pretty good snapshot of where every state is.
Yeah. And apparently that depends on where you live, Mike. That was you. You said it twice. So somebody just pointed that out.
Yeah, it definitely does. Some states have lower prices than others for sure.
Yeah. Can I get the panel's opinion on life insurance policies with long-term care riders as opposed to a traditional long-term care plan?
Stefan, I'll let you kick that one off.
Sure. So I think this is kind of a little bit of a continuation on the response that Dana had regarding, what's kind of a net worth where somebody can self-fund instead of consider their insurance options. There's been an overall trend, as I talked about, in the industry towards these hybrid policies that have life insurance and long-term care combined. And the reason that people are gravitating towards these, because they're looking for some of that certainty and the fact that they're not going to lose their benefits if they don't use them. Meaning, right, once the premiums are guaranteed, right, they're not subject to any potential rate increases that traditional have, and also that if they don't use the benefit for long-term care while they're alive, right, they know that it's going to go to their family. So I would say the majority of the time people go towards those hybrid products because they have a desire to leave something to somebody after they're gone, right? And there have been instances in conversations I've had with couples where they say, really, the only thing we're looking to insure here is our long-term care risk, and we don't really care about anything else after that. And they're looking for probably the more cost-effective solution, right? That's more of a candidate to explore further traditional long-term care. But for those individuals who say, hey, I want to preserve this. I don't want to waste funds. I want there to be something if I don't use it. That's where the hybrids, where the life insurance comes in. And that really kind of is, I think, a little bit more attractive to the higher net worth folks, because they know that if they don't use the product for long-term care while they're alive, there's going to be a life insurance benefit, right? It's providing more value. So just in general, from an emotional standpoint, I would say, not necessarily financial, right? Long-term care, I think, is an emotional decision. From an emotional standpoint, it gives peace of mind knowing that one way, shape, or form, these hybrids with the life insurance, it's a benefit they're going to use while they're alive, or that it's going to go to their family.
Okay. Mike, I think this is going to be for you. Can I get for Cobra? I'm primary insured. Will be switching to Medicare. Have spouse and dependents still needing insurance. What is the situation where they can still be covered for 36 months?
As dependents, sometimes there's extension options and things like that. So that's where you want to look at it. But that's really where we're going to want to dig into the specific situation and look at the details at a fine level.
Okay. Question has come up a few times. Will the slides or recordings be sent out after the webinar? Yes, we will. Within a week or two, Susie will get those out. How can we coordinate manufacturer discount cards or GoodRx type cards with Medicare? Can we use one or the other, but not both?
So I encourage everybody just to find the best deal that's possible. A lot of times if you go to the pharmacy and you have some sort of Medicare-based prescription coverage, a good pharmacist will actually compare the pricing between potentially using a discount card and the Medicare plan itself, and you do get to choose. Do I want to do that? Just kind of a little warning there, though, is if you fill a medication with a GoodRx card, it won't count towards that max out of pocket because it's out of the insurance, but only you can decide what's the value there. I always encourage everybody just to pursue the maximum amount of savings possible.
We spend about half our time in Florida and half in Massachusetts. Pre-65, other than Cobra, is our only option for national care off an exchange plan.
There are other options available depending on what their circumstances. So that would be one of those, want to have a conversation about it type of questions.
Yeah. Is it true that if people can afford, they should choose a Medigap instead of a Medicare Advantage plan? I think you may have covered this. I read and hear bad stories when people need benefits and they have Advantage plans, very few positive stories. That's how I've created a reminder to myself. Advantage plans are only to take advantage of me instead of helping me. LOL.
Yeah, that's it. That's a little bit more nuanced. I mean, I have clients that do both. Some people really enjoy the Advantage plans and they work really well for them. Ultimately, what I do is I just lay everything out in front of everybody and I let them know. And the reality is, just like we said earlier, sometimes if you start with an Advantage plan and you desire the supplement, it could be challenging to move that way. So it's a lot easier to start with a supplement and go to the Advantage plan later on in years than it is vice versa. Again, it's just whatever makes you feel the most comfortable based on your circumstance. But, like I said, there is a high level of freedom with original Medicare, and then you have the network-based coverage. So there are a few more knowns about that, but, that's for you to decide yourself.
Yeah, and I think some of that misconception comes, or some of the horror stories is because people don't understand the Advantage plan, right? So a lot of times, if it's marked as zero premium, and then someone is thinking, wait, well, how come I have all these costs? They didn't understand the risks to begin with. And so that can certainly create that, wait a second, I didn't think this was how it worked. And so I think it's really important to understand, I've seen some questions come in about people who travel. If you're going to be in multiple locations, the Medicare with the supplement is going to be your better choice because it's your choice of providers. So where those horror stories come from, can be people with an Advantage plan, they end up seeing an out-of-network provider, or their primary care provider or whatever, people they normally see decide not to take the Advantage plan anymore. So there have been those situations where those are, I think, where some of those stories are coming from. It's really about making an educated choice.
100%. And I would say, when you sit down with me, I start with the education piece where I really want you to understand those options so that you can make a highly informed decision. And it is your decision to make. But like Dana said, yeah, I think a lot of times people are caught unaware because some of the details fell through the cracks of how it actually worked.
Now, I've also heard, not to put you on the spot, Mike, but people get leery because they say the Advantage plans pay higher commissions to the agents that sell them. And so there's been people out there saying, oh, well, that's the only reason these plans are getting sold. And so, I believe there's educated people that are going to provide good education, regardless. And that's what you really need, is to be making an informed choice and make sure that you've got a plan that's right for you. I've seen retired financial planners who have Advantage plans, and they, went through the whole analysis and felt like that was absolutely the right choice for them. Now, again, we often will recommend our clients go with the Plan G supplement because we are looking at it from that maximum out-of-pocket risk perspective, and we want to cap the maximum out-of-pocket. But if you had no big health events, you could end up paying more for that over time.
You could, yeah, and that's a very true statement that you said. There is some truth to the compensation involved, but again, if you're working with a good advisor, it's just, here are the facts, and you make the decision. And you shouldn't, if somebody's kind of steering you one way or the other very early on, that could be something to take note of in your decision making there about who you're working with. But yeah, ultimately, whatever ends up being the best choice for the client is what I want to help with.
I turned 65 at the end of April in 2027. Will I have to pay for marketplace insurance and Medicare at the same time? When would I need to enroll? I think it's when would I need to enroll, question December 2026. Also, don't forget to mention long-term care help with veterans benefits for those who qualify. I learned that with my dad.
Yes, so very simple answer to that one. You should never be paying for marketplace coverage and Medicare at the same time. That means something has gone horribly wrong. So technically, when you become Medicare eligible, you want to get off of the marketplace coverage if that's where you're at, and just make a clean transition into Medicare coverage. You're no longer eligible for tax credits when you turn 65. If you're not working, there's no reason to be on the marketplace. You don't want a surprise tax bill at the end of the year because basically they'll deem you ineligible for any help you were getting. It's not great.
Can the insurance companies that cover Part D drop your medications mid-year? And if so, what is one to do?
There is technically the ability to move some drugs in the formulary within the first 2 months of the year. I don't see that happen. I can't really remember that it's ever happened that I've seen, but you always want to make sure, again, when you're doing your analysis in the fall, that all of your medications are covered for the next year. And then you can look to, let's say that something came up that wasn't covered very well or at all. There's alternate ways to get it paid for, either through reputable Canadian pharmacies, discount plans, manufacturers' discounts. There's other avenues to pursue getting medications if they come up on a surprise basis.
Does Medicare cover if I'm out of the country? If not, would you get a Medigap plan?
So Medicare itself does not work out of the country. There is a foreign travel benefit baked into both many Medicare Advantage plans, as well as a standard feature on most modern Medigap plans. I usually advise people that this is just enough coverage to kind of get you patched up abroad so that you can get back to the States, and then Medicare can take over and get you where you need to go long term.
Yeah, and I don't know what your thoughts are, Mike, on the travel insurance, but I think when you're traveling abroad, it's worth it. We had a client this year who, called us. I think they were in not Venice. I don't know why it's slipping my mind, but they were overseas and husband had a heart attack. And so they had to stay. Initially, they were quoted $240,000 to emergency vac him back to the States. that was exorbitant, but then they realized if he could stay there and be classified as stable, they could get a different kind of transportation back that was still about $40,000. That's what they ended up having to do because they needed a qualified medical person to be traveling with him. And so that's where, I think that travel insurance that can cover those kind of events can be well worth it.
Yeah, absolutely. I advise everybody, I mean, if you're going to be out of the country really longer than 2 months out of the year, you absolutely should look at that from a safety perspective. And, even if you're not for a shorter amount of time, it's relatively inexpensive to buy that travel insurance and can give a lot of peace of mind.
I'm taking notes because of our little trip coming up, and my husband's a little klutzy sometimes, so I can see something trip thing. And anyway.
Yeah, we've got a big trip, a hiking trip planned next summer in Switzerland. And so, I absolutely bought the travel insurance. I'm like, you don't know what's going to happen. I know what the cost can be. I'd rather pay the travel insurance.
Yeah, no, absolutely.
Remember, the insurance is there for when things don't go as planned.
That's, yeah.
Yep.
If I turn 65 late in the year, can I contribute the full year amount into an HSA?
No. I should say it depends, right? It's
Right.
not the turning 65, it's the enrolling in Medicare. So if you're turning 65 and you have creditable coverage, you work for an employer with over 20 employees, then you would still be able to fund your HSA. But if you turn 65 and Medicare starts for you at 65, you enroll in any part of it, so just even Part A, then you could prorate your contribution to your HSA that year for the number of months before Medicare started.
If you are over 65, still working and covered by employer's insurance plan, why would there be a penalty? Are there other parts you're supposed to enroll in? Or if signing up late, would you be penalized? I thought if in an employer situation over 20 employees, you're safe from penalties.
No, that's accurate. So if that's your situation, you will have no penalties. You basically get to choose when you want to start your Medicare. So basically when you retire, or you go work for a company that doesn't give you the appropriate, or I shouldn't say appropriate, but the creditable coverage required to delay it. So if that's your situation, you're safe. Only thing to look at is make sure that the drug component of your insurance is creditable. Again, with that $2,000 cap this year, that changes that definition for a lot of employer plans. So you just want to make sure that you're on the right side of it. If you are, you can actually do that until I have a client of mine that retired at 87, didn't have Medicare Part B, no penalty. He had creditable coverage the whole time and was just fine.
Yeah, and we didn't touch on that, what we called special enrollment period. So if you're transitioning off creditable coverage, is it 8 months? I can't remember what the window there, but there's a special enrollment period where you can then enroll in Medicare. How does that work?
Yep, you get to do that 3 months in advance of your start date. So if you said, whenever that is, you have 3 months in advance to do the paperwork to request that your Medicare Part B really start on that date. So that's part
3
of,
months.
Yeah, final planning for retirement there.
Do you apply for Social Security before applying for Medicare, or at least get the application in so it is ready for the date you wish to start Medicare?
So they should be distinct and different decisions. So when you start Social Security as a financial planning decision, there's all kinds of reasons that we will often recommend someone delay the start of their benefits till age 70. Depends on if you're married or single or have a prior marriage over 10 years, or if you're a widow or widower, there's some special options. So there's all kinds of cases where there may be a reason to enroll before 70, but in many cases, we're encouraging people to delay. So in that case, no, those two would not coincide, because in many cases, you'd be enrolling in Medicare at 65, but you would not be applying for Social Security benefits until later.
Yep. You don't need both at the same time.
Is there an age at which it's too late or it doesn't make sense financially to get long-term care coverage? And what if you have pre-existing conditions?
So I think that answer, I think it's a common answer, right? It depends. But you can talk a little bit about the pre-existing conditions. So when you're going for long-term care insurance, there's no exclusions for certain health conditions. You're kind of either in or you're out from a health perspective. So what I like to do when I'm having conversations with individuals and couples is to really kind of gather information on looking what they're trying to accomplish. And part of that conversation dives into health history, right? So we do a really good job of pre-screening people and asking the right questions from a health perspective to, number one, see if they're eligible. Now, in regards to older individuals looking at this, I think a lot of times it comes down to kind of the cost benefit analysis and how it fits over into the overall financial plan. What's nice about some of the hybrid products that are available out in the market today is you can choose your funding pattern for them, meaning you can pay every month for the rest of your life, or you can even choose to pay them up in one lump sum, right? And the shorter duration that you choose to fund these contracts, the less likely that you're going to go what's called underwater, meaning you're not going to put in more money than what you get back. So as you do get older, the desire or the what makes more sense, I guess, to implement a short pay scenario or a shorter funding period, so that you always are coming out ahead from a benefit perspective makes a lot of sense. But I think that it does involve, right, going through the conversation and going through the options and kind of doing that health screening and showing you solutions that do fit into your overall financial plan.
And Stefan, that touched on a question I forgot to ask, which was, what age should people begin looking at long-term care?
Yeah, no, and that's, well, we got to it eventually, right, Dana?
Yep.
The trend in the industry overall has been younger and younger, because from a pricing standpoint, right, the older you get, the more health issues there may be. You may not be eligible for coverage. So I think we're encouraging the people that we work with and we speak with to have those conversations earlier and earlier, because it's not something that you necessarily want to wait until retirement for. A lot of times, because of the ability to pay these up in a certain period of time, we can design them so that you can enter into the contract in your 50s and have them paid up by retirement, so that your cash flow is fairly set, at least from an outflow perspective, when you do get to that point in your retirement. So overall, right, the younger the better, the younger the healthier, and the ability to get a more a premium outlay that fits.
Any tips or rules of thumb on managing, it says managing AA and decumulating it in HSA? I'm not sure what is AA. I don't know. Since it is not good to leave to heirs, is HSA similar to a 529 plan in a sense of being aggressive very early but conservative within a few years of college? When to take the last dollar from the HSA? Our HSA is 100% U.S. stock ETF, but not planning to retire within 3 years.
So generally, I would agree. Yes, keep your HSA aggressive.
Asset allocation, AA. So.
Yeah. So, yeah, I was thinking, my mind went to Alcoholics Anonymous. I was like, wait, I don't think that's what they're asking here. But yeah, like I'll tell you, my HSA is also 100% equity. Yeah. But when I was younger and didn't have financial resources, I would keep at least 2 years worth of deductible in the money market in my HSA. So I would fund it and keep it in that money market because that was part of my emergency fund. And as I was able to build up more liquid assets, then I said, okay, now I'm going to transition my HSA. It's 100% equity. A good plan that we've started using is spending it between 70 and 80, and it could cover long-term care premiums, as we've talked about. It could cover your Medicare Part B premiums. And so you can budget that out And then it would be easier to determine that asset allocation once you knew when the withdrawals from that were going to start.
When you sign up for a Medigap plan initially, you're protected because they can't refuse to cover existing conditions or charge a higher premium. If you stay on the Medigap side of things, do those protections stay in place if you decide to switch Medigap plans down the road and or decide to switch insurers, for example, United Healthcare to Aetna for some Medigap plan?
The answer is unfortunately no. So you get a 6-month period when you start that allows you to choose any Medicare supplement within that period, no health questions asked. Starting in month 7th after Medicare Part B is active, so even if you retire late, that still carries over. You get to change, but then you can move any month that you like, but it's predicated on being able to answer those health questions on a no basis. So good news is if something has come up, they can't cancel you. It's guaranteed renewable. But if you do want to shop around, you can. And worst case scenario, if you get declined for a new policy, you stick with exactly what you have and no harm, no foul.
Mm-hmm. Are high deductible plans available in all states under ACA? I'd like to have one for my wife instead of her current Cobra, but I didn't see any offerings in North Carolina. I want it mainly to get an HSA, but no options that I see. Due to our investment income, we don't qualify for much ACA tax credit. So Cobra was our best option for her since I'm already on Medicare.
Yep. So you can just look at what's available. They're available most places. I think if you looked into it, there might be one available out there. But again, if it's available and you want it, you can have it.
But it does vary state by state. I know,
Yeah.
the options.
All the plans. Different, HMO versus PPO, high deductible health plan, they all have different plans. So yeah, you just have to find what works for you in that state.
So if I have Advantage plan and I want to switch to a supplemental plan, I will have to pass medical underwriting. If I want to switch to another Advantage plan, there is no underwriting. What if I have supplemental plan G with one, you just answered this, I guess, right? One provider want to switch to plan G with another to save on premiums. So I think it's really just if I want to switch to another Advantage plan, there is no underwriting. And
Yes, absolutely no health questions asked. It's yours to just move freely within a valid election period like we're in right now.
You see, valid election period, not that election, different election.
Not the political election, the health enrollment election.
You don't get to choose a new Advantage plan every 4 years. It's every year.
Yeah, that's right. If you enroll in Part A because you're 65 plus, decline Part B because you're still covered by an employer plan that also has drug coverage, and when you retire, you select Part B but have no prescription drug needs, will you incur a penalty if you don't sign up for Part B at that time, but wish to do so later? Part D, but wish to do so later.
You would. So my advice there is if you take no medications, you just want to find something that's efficient, meaning that it has the lowest cost to put that coverage in place to avoid the long-term penalty, because it does grow. That national average that determines that penalty times the number of months of non-coverage does get larger from year to year. So yes, you want to have something in place. There are very affordable options to do that. You should never forgo having creditable drug coverage. Carve out there, if you do have VA benefits with the pharmacy, that can count as creditable drug coverage, as well as Indian Health Services. There's a couple of other things, but yeah, just as long as you have drug coverage, that counts.
And if you overestimate income for Affordable Care Marketplace insurance application, do you receive a rebate or an adjustment on subsidy premiums, parentheses credits, when filing your tax return?
Yeah, it works. Yep, works both ways. If you overshoot your income, you're probably due a little bit of money back because you should have had more tax credit. If you make more than you said, you're actually maybe going to owe a little bit of money when you do your tax return. So just want to try to be accurate with your income figures.
Have original Medicare Plan F and supplement for F. Have original Medicare Plan F and supplement for F. In checking the supplements this year, I find premiums from $180 to over $290 a month. I do not have a deductible. Are not all supplements covering the same things?
So the supplemental plans are all standardized. So a Plan F is the same from one carrier to the next as is a Plan G or a Plan N. The difference really is based on location, your age, smoker, non-smoker, some of those demographic questions. But yeah, there can be a very large premium difference depending on what insurance company you're with.
And I also heard some of those premium differences had to do with potential increases in the future, right? So how they were pricing that policy and then, what they might expect to happen in the future. I'm not sure if I'm making sense as I'm saying that, but I had just heard that. I hope I'm getting it right.
No, so Stefan kind of hit on this with some of the long-term care policies is, those premiums that as they increase, they have to be approved by the state. So the Medigap policies are actually regulated by the state insurance department. So every year they come and if they want to file a rate increase, they have to do exactly like what Stefan said. They have to show with math why they need to increase it by X number of dollars every month or a certain percent. If a company has done a poor job of factoring in their claims history, you could see more aggressive rate increases. So what I kind of, not as an absolute, but it's kind of like hiring a contractor. You don't want to hire the most expensive contractor. You don't want to hire the least expensive contractor. Somewhere comfortably, maybe in the middle of the pack is going to be a steady Eddie option for you. So not to say that you can't get a better deal from year to year. I just like kind of looking at long-term stability within one insurance company for the same type of policy that you can get.
When is it appropriate to consider self-insuring for LTC?
Stefan, you want to share thoughts and I can share some thoughts on that?
Yeah, I mean, I think once again, I think we'll call it self-funding, right? Whether you can self-fund or not. I think it's more or less around a general conversation. Could you use a number and say 2 million, 3 million, 5 million? Sure, you could, but I think a lot of times it's more important to have the discussion about what your plan is for long-term care, and then from there determine whether or not self-funding is the best option for you. So there's no kind of, in my experience, the people that have the more wealth, more assets, they tend to end up purchasing the products because they see they're passing off the risk to a third party. And these people are typically purchasing the hybrids, the ones that combine the life insurance, because they know that if they don't use the long-term care, there's value coming back, right? There's the insurance benefit coming back to their families. So there's not, unfortunately, a set hard rule by saying, hey, here's the number and you're good to go. But in my general experience, it's about, talking about what your plan is and then determining what makes the most sense from there.
Yeah, and I would add, I mean, we use math and we project it out and we say, well, if a long-term care need were to occur and, it was an extended, say cognitive decline stay, here would be the cost. If you are married and you had a healthy spouse still at home, then you would still need funds to maintain their lifestyle. And how well does that work in your financial plan? If it spends your assets down too rapidly, or is there still a nest egg left at the end? And even if there is that a risk that you want to retain, or do you want to shift that risk to the insurance company? And so it becomes an individualized decision where you can chart it out and take a look at the impact and then decide how you want to manage that risk. Nancy, I know you would go on forever, but we need to wrap up. I know we'd love to.
No, I wouldn't. I was wondering. I was wondering when you were going to say, "Okay, let's." I have one last question, if you want to.
Let's do it. Last question.
All right, because it's Stefan might have some thoughts here. I also have Medicare Part D, which I pay for but wasn't using as it was cheaper to get prescriptions from this discount program. I found out it isn't legal to get prescriptions from Canada. So what are you do? You have all the good stuff up there.
I like the shout out for Canada, but I would defer to Mike on that question if there's any knowledge that he can pass along on that.
No, you can use Canadian pharmacies. The only thing I recommend is just making sure you're working with a reputable one. So if your doctor, somebody who prescribes you a prescription, go to them, see who they kind of work with, and that can be a pretty good indicator. But there are actually pharmacies in the US that source drugs from out of the country that you can use too.
So this person maybe just needs to find the right source and could use Part D to pay for some of these drugs that would be coming in from Canada?
Oh, no, it would not
Okay,
be
I
running.
think that's the question.
Yeah, that Medicare doesn't work out of the country, therefore you can't buy drugs out of the country with Medicare Part D. I just meant as an alternative to maybe an expensive drug here in the States.
Right. Okay.
Yeah.
Yeah, I think that's what this person's doing, but just it's not being covered by Part D.
Yep, that makes sense.
Okay, so Dana, that would be that wraps up.
Yep. So we would love to stay on. We're sorry if we didn't get to all of the questions. We have so many people that stayed on. It's really quite amazing. This has been 2.5 hours, and as you can see, we could answer questions here all day long. Contact information is on the website or on the screen for both Mike and Stefan. And I will make sure we send out a PDF of these slides along with the recording. So you'll have this information handy. Thank you, everybody, for being such a wonderful audience and for all the fabulous questions. And hopefully we'll see you at the next one.
Okay.
Bye, everybody.
Thank you.